individual. But nevertheless, welcome to this 2024 Global Solution Room. And one of the slides will give you a little more background on Global Solution, but G for global and naturally local for local. But many of the solutions we have to healthcare related dilemmas that we discover locally, sharing them globally is always encouraged. And so hence the notion of a Global Solution Room. And it's a week-long event whereby JBI entities around the world can participate. And of course, the sessions are recorded and you will be able to access them through JBI Global afterwards. So welcome everyone, and you'll get further information around JBI and Global in the next few minutes. But I would like to hand over now to Dr. Laurie Weeks, who will do our land acknowledgement. Laurie.
Okay, thank you very much, Marilyn. I'll get my camera on here. Kathleen, if you can just advance to the next slide for a moment, and then I think we're back to Marilyn.
Yes, Laurie, you should have control of the slides now as well.
All right. There, we have many people presenting today, so we're just getting ourselves organized here. It doesn't seem to be advancing. There we go.
There we go.
Okay.
Must be a delay there.
Yes, and welcome everyone. It's lovely to see you all here. So I will be talking at different times throughout this webinar. But first of all, these are the acknowledgements. Of course, we know that there are many people joining us from many different places in the webinar live, but then also who might be joining us and watching the recording later from different places in the world. But we are located in Eastern Canada, and Kathleen's going to show you a map shortly if you're not familiar with the geography. But Dalhousie University is located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq, and we are all treaty people. And secondly, we also recognize that African Nova Scotians are a distinct people whose histories, legacies, and contributions have enriched that part of Mi'kmaq known as Nova Scotia for over 400 years. So for me, I don't like to just read the words there, but just talk just really briefly about what this means to me as a person who is of European ancestry and a settler in North America, and how I'm very committed to supporting people, and especially the people that I work with and in the university setting and the students that I support, and trying to do my best to learn and respect and support diverse students and colleagues as much as I possibly can. And I know Marilyn often likes to add as well to these specific acknowledgements, the Acadian community, the French community who has been in this part of the world for a very long time, and the history and contributions of people who are Acadian.
Thank you, Laurie. Okay, so here at Dalhousie University in Halifax, Nova Scotia, we do have a JBI Center of Excellence. The name of our center is Aligning Health Needs and Evidence for Transformative Change. And of course, the acronym ANETSI, for those of us locally rather than say the full title all the time. And then you see the logo with the red ball, and then that's like a wave or a ripple. And so the idea behind that is that with each and every bit of knowledge that we generate, when dropped, wherever we drop it, has that ripple effect. So that's the short version of the logo. Next. I didn't say that I am Marilyn McDonald, and I'm the director of our JBI Center at Dalhousie University. And you see, following your introduction to JBI, you're going to benefit from this amazing webinar, and the moderator of which will be Dr. Laurie Weeks, and then the panelists are listed here: Elliot Paz Jensen, Anne Beliveau, Dr. Elaine Moody and Dr. Lori Weeks.
Marilyn, I think that we somehow have some slides from a previous local webinar maybe here.
Yeah, I was saying, I'm not sure where these came from. Oh, that's the slide I'm looking for. Yeah, pardon me for that. That was, I'm not quite sure how that, we tried to merge two slide decks and ended up with slides that shouldn't be there. So Dr. Zoe Jordan is the executive director of the JBI, and the social seat for JBI is Adelaide, Australia, which is where Dr. Jordan lives and works, and brings to us today around the world, for all centers around the world, a message from JBI Adelaide. And so this is a short video, and we'll see how well it plays. We've had issues with it in the past, so we'll give it a try. And if it doesn't play for us, we'll just continue.
Marilyn, I'm not sure that the video was transferred over, so
Okay.
I apologize about that.
Okay, no problem. We'll just move on.
Okay.
Go ahead, Lori.
Okay, thank you very much. And I didn't really introduce myself very well either, but I'm Lori Weeks, and I'm a professor in the School of Nursing at Dalhousie University, and I'm also the interim coordinator of the PhD Health program. And I've really enjoyed my involvement with JBI ever since I came to Dalhousie, almost, I guess it's 10 years ago, in my 10th year now. And Marilyn provided me with opportunities to complete the JBI Comprehensive Systematic Review training, and then also to become a trainer. And our center just completed very recently the 5-day training program. So it's lovely also to participate in this local event and sharing some of the work that myself and many others connected to our center have been involved with. So I'm very pleased that our webinar that we're doing today is focused on some of the research that I've been involved with for quite some time. So I'm going to talk to you about the results of a scoping review that was really the foundation for a current study that we're involved in implementing. So I'll give you some of that history, some of that background, and because this is a JBI event, really showing how that systematic review process laid the foundation for all of these other activities we're going to talk to you about today. I'm just coming off of a cold, so I might mute myself a few times and cough. So after talking a bit about the scoping review that really was foundational for this work, I'll give you an overview of the AIM study. And then I'm very happy to have Kathleen Allen joining us today, who's the research coordinator for the AIM study. And she's going to talk about some of the key components that she's been very involved with, and specifically around the community-based research work that we've been doing and working with various organizations throughout the region to work with people to deliver our AIM program. And maybe Kathleen, we could talk at some point a bit about sustainability and how we've kind of incorporated that. I'm not sure if that's clearly on our slides, but it's a very foundational, I think, to this work. And then I'm very pleased to have Jennifer Fraser-Farrow join us, and she's been very involved as trained and has been delivering the AIM intervention. So it's lovely to have her connected with us today and talking about this very important involvement with delivering the AIM intervention. And then hopefully at the end, we'll have Jennifer Perley join us as well, and some of the ways that she has been involved with their work and really adapting it for use in a way that we didn't originally intend, but it's great to see applications of this work and how she's using that work in adult protection, which is the area that she works in New Brunswick. So we have a lot of folks who will be doing part of the presentation for you today. So the first section is Marilyn is going to, I think this might, I think we already did this. Is that right? Maybe this is where some of those slides were, Kathleen.
Yes, there's some slides here, Marilyn, that that you might want to touch base on, or maybe you've already covered them, but I will give you control so that you can go through them yourself if there's anything else you wanted to add.
Yikes. Ugh. Painful. It was there, but it's disappeared. So. Can I add there? Okay. So about JBI, I think probably what I'd like to point out in this slide, I've already said where JBI is based, but the vision, better evidence, better outcomes, brighter future, nice, crisp, easily understood vision. And then, of course, the mission, promoting and supporting evidence-based healthcare. And I would dare say anyone on the attending the webinar is somehow related to healthcare. Next. And so to give you some idea of the scope of JBI worldwide, you can see here there are more than 85 centers and affiliate groups around the world in over 40 countries. So it's quite an exciting enterprise to be part of. And we became a center in 2018. Previous to that, we were an affiliate group, which is step one of the process of becoming a center. Next. And of course, the framework that JBI uses in relation to all of its work. And you can see in the, you have the red circle in the center with the logo. And what the aim is that what is produced feasible, appropriate, meaningful, and effective. And so the business of JBI, if you will, and all of our entities naturally is to contribute to global health. And how we do that, the green evidence generation is one of the pieces that JBI, evidence synthesis, evidence transfer, evidence implementation. So all of that comprises, some centers are more focused in evidence synthesis. Ours does more synthesis than implementation. But what you're going to hear about today is an excellent example of implementation. And of course, evidence transfer. I think all of you do some of that or a lot of that in relation to any and all of the products that or projects that you're involved in. And then in the outside circle, all of the skills and abilities that contribute to doing this work. Next slide. This, of course, is a slide just depicting our center at Dalhousie University. Next. And away we go. Back to you, Lori.
Okay, thank you very much, Marilyn, for that introduction. It is, I know many of you probably have a background in JBI, but it's really good to situate us as part of our center, of course, at Dalhousie University, but also as one of the JBI entities globally. So I'm going to first start talking about, as Marilyn referenced, a scoping review that it has been used, and we'll talk about some of the ways it's been used in the last few years. Okay, I think there we go. We're sharing control of the slides with a few people. So thank you, Kathleen, for keeping us all working. And we're all in different places, of course. I'm actually joining you from Toronto today. So it's in a slightly different location than usual. So this is just a screenshot of the cover page of the review that I'm going to be talking about today, a review of intimate partner violence interventions relevant to women during the COVID-19 pandemic. And several of the people on our team today are connected to us. I see Christy's here and of course Marilyn. And we have several other people who were part of the team at that time. So this was actually quite recently published. There's always, of course, a time lag between when research is completed and then published online usually, and then actually appears in a volume of a journal. So this was really very recently published in the journal Violence Against Women, although I feel that the work has been completed now for quite some time, and we certainly didn't wait till the final publication stage to be utilizing the results of the work. So the rationale for this particular synthesis work that we did at the time, this was very early in the COVID pandemic. So we were starting to hear a lot of information from the World Health Organization and others as well that women we were starting to see increased rates of intimate partner violence since the onset of the COVID-19 pandemic. So that was some alarming things that were occurring and were starting to be seen and reported on early in the pandemic. And just the context of the pandemic at that time where people were forced to socially isolate, to stay at home. And, for people who were in an abusive relationship, this was a very difficult situation. So for women experiencing IPV, they had increased periods of isolation at home with abusers. So there was really challenges where isolation is used as a tactic to control other people in situations of intimate partner violence. And just the nature of what was happening during the pandemic at that time was situations that were very difficult for people experiencing abusive relationships. And also the circumstances surrounding requirements to physically distance during the pandemic really created some challenges in accessing services. In a lot of cases, supports and services for people experiencing intimate partner violence may have had to close or at least stop their face-to-face operations, and in some cases even shelters might had to implement social distancing and possibly had less capacity because of that and the numbers of people that they could support. So there's a lot of things happening around intimate partner violence and supporting people experiencing intimate partner violence. And these things were starting to be shared early in the pandemic. So as a academic who had been involved really for my entire academic career, starting in the early 2000s, I had been involved in research related to elder abuse, gender-based violence, and then gradually started focusing on intimate partner violence towards older adults and women in midlife and older in some studies as well. So these were some things that our team kind of quickly started to think about, and what could we really contribute at that particular time using our abilities and knowledge about the context of intimate partner violence and what was happening during the pandemic, but also utilizing our knowledge synthesis skills. So the purpose of the systematic review was to focus on how can intimate partner violence services for women across the lifespan, because I haven't specifically mentioned it yet, but I am a gerontologist. I focus on later life in general. So we felt, though, for this particular project, it was important to not specifically focus on older women, but women across the lifespan. So we were interested in understanding through knowledge synthesis work how IPV services for women across the lifespan could be adapted within the context of the COVID-19 pandemic, where those two factors were very quickly a part of daily life, physical distancing, and then how could remote delivery of services be incorporated in these types of services. And then also, secondly, what evidence exists for the impact of these services on the health and safety needs of women. And thirdly, what evidence exists for the feasibility and acceptability of these interventions. So again, this was, so many students I work with and colleagues and myself early in the pandemic were really pivoting. We use that word quite a lot in terms of the focus of our research. And this was one that we initiated early in the pandemic. So the framework that this work was based on, I'll talk about a couple influences and then how as a team we use these frameworks to guide the systematic review work that we did. So our work was based on the levels of prevention, which I'm sure that many of you are familiar with. So and thinking of it within the context of intimate partner violence. So primary prevention, which is preventing a problem from occurring and addressing the underlying causal factors. So again, we're thinking of these things in the context of IPV. So a lot of awareness raising kind of things can occur in understanding the contributors to IPV and then addressing those underlying factors. Secondary prevention, screening and early detection to implement early interventions to reduce the impact and specifically related to IPV. And then tertiary, which is probably the one that is perhaps less focused on, but I think is very important in these contexts, which is mitigating the impacts of current or previous experiences. So people who are exposed to something, it's not primary prevention, but it's still secondary and tertiary are very important types of prevention to think about. And then in addition to the levels of prevention, our team was also very influenced by reclaiming self theory. And I've included some of the references to this work, and the full reference list is at the end of the slides. This work was really informed by some of our colleagues at the University of New Brunswick. You can see Merritt, Gray, and Weist as referenced in a few of their papers that they have published quite a while ago, but the work is very influential. So, they identified 4 stages essentially, if you would like to think of them like that. So, when people, this is a lot to do with the dynamics of abusive relationships and the way that people who are experiencing intimate partner violence think about the abuse, think about a sense of agency that they might have, and whether that will influence them in seeking help and trying to make changes in their life. And it's really, in this context of our work, it's all about understanding these different stages and really targeting interventions specifically for women who are at different levels or stages. So very briefly, counteracting abuse in terms of reclaiming self-theory is the stage where women tend to relinquish valued parts of their self-identity, minimize their abuse, and fortify their defenses to leave the relationship. So you can kind of think of that as quite early on in the stages of really understanding the context that people are in, and thinking about the early beginnings of maybe thinking about ways that they could perhaps make some changes in the situation that they're living in. And then the next stage, kind of chronologically, I suppose you could think about it, is breaking free, where women would actually physically leave the relationship. We know there's lots of references around, it's usually just not that simple. For people who don't understand the dynamics of abusive relationships or perhaps haven't had direct direct experience in some way, it very rarely is so simple as someone saying, well, I'm experiencing abuse and I'm just leaving and that's it. It doesn't usually happen that way. Many times people do return to abusive relationships for a whole variety of reasons. The third one here, not going back to the abusive relationship, is really when the person has worked through that piece and they may have left multiple times and returned, but they really have come to a decision that, you know, this relationship does need to end and they're not going back to the abusive relationship. And then finally moving on, which is the final stage of the abusive relationship is over, that it's permanently behind them, and thinking about then what happens next and what do I do now, kind of thing. So again, I find this work really, really helpful in understanding the dynamics of abusive relationships, but very importantly, I think making sure that we target interventions, supports, programs specifically to meet the needs of women at different stages of abusive relationships. I'm saying the word women a lot here. We know that you know, a person of any sex or gender, you know, experiences violence in relationships. We focus primarily on women or people who identify as women specifically in this work, but I just wanted to mention that we certainly recognize that people in all different contexts experience violence in relationships. So what we did, this was really quite fun. I would probably say that, you know, this was, we really worked as a team to think about the levels of prevention and reclaiming self theory. And you can see kind of how we kind of thought about these, and there's certainly overlaps. And you can see reclaiming self theory doesn't really focus on primary prevention, but starts when people are starting to think about, you know, dealing with the abusive situation. But there was a lot of overlap, and both levels of prevention and reclaiming self theory really helped us to identify the 4 categories on the right-hand side. So in the scoping review, I think I would probably at this time use the words framework analysis in a sense. So what that meant to us is that we had identified these 4 categories. So essentially, as we identified through the systematic review interventions that fit our inclusion criteria, we were able to kind of sort them into these 4 different categories. So we use that really as a framework to help to guide the systematic review work. So we essentially identified interventions, program services into these 4 levels. First of all, preventing IPV. Number 2 was identifying IPV. 3, supporting women while living with and or leaving an abusive partner. And then 4, supporting women after leaving an abusive partner. So I'll show you in a little bit the ways that we really some examples of interventions and descriptions of these in a little more detail. I'll give you a little bit of a sneak peek, though, that the way we use this in the current study that we're doing now is really thought about what interventions are there, which focus do we want to have. So this work was really helpful in the current AIM study, where we decided to focus on our intervention on number 3, was supporting women while living with and or leaving an abusive partner. So I skipped ahead a little bit, but just to show you kind of those connections between the systematic review work and the current work that we're doing with the AIM study. So the inclusion criteria for the review that we completed. So with JBI and with other types of systematic reviews, we often use the acronym PICO, and depending on the type of review, those elements can be used in different ways to really provide a framework for the review that you're conducting. And so the PICO elements that we really guided that review that we completed, first of all, was the population was women and those who identify as women. The intervention or phenomena of interest is the I component of the PICO. So interventions that involve providing services to women who experience IPV. the context. So we did limit it to English or French. This was, I wouldn't say formally the review was a rapid review, but we included elements of a rapid review, mainly because the work, we really felt strongly the work we were doing was very timely. And if the work was going to have an impact and we were focusing on COVID, we really needed to try to complete this review as quickly as we could. So we did limit the sources to sources published in English or French, which were the languages that the members of our team were able to work in. So we focused it on studies that investigated or described interventions specifically provided within or adapted to a COVID-19 context, or are delivered in a format that could be utilized during the pandemic. So we were really hoping, knowing that this was early in the pandemic and how long it can take to not only complete a project evaluating a specific intervention, but then to actually have it published. We did not feel that we would be able to identify research that was instigated after the pandemic began and was already appearing in the peer-reviewed or grade literature. However, we were definitely including studies that involved interventions that could have been delivered during the pandemic. So if it involved socially distancing, if it involved virtual delivery, for example. So we very much could use that context for the types of interventions that we included. And as a sneak peek into the results, we didn't find any formal studies that were published that were initiated after the pandemic began, but lots of studies that the interventions would have been perfectly valid within the COVID context. However, we had an interesting component of the study. Well, really fascinating for me, and I'll talk about that a little bit more. But we decided to include as a component of our work reports from the media because very, very early in the pandemic, I'm talking like spring of 2020, really starting in March, there were things that were reported in the media around ways that service providers were adapting and modifying IPV services to be able to adapt them to the COVID context. So for a part of our work, we decided to include those media reports as a form of evidence. So that was a very interesting component of our work. But the studies, the actual formal studies, were all completed prior to the pandemic, but could have been useful during the pandemic. And then we did include outcomes. The outcomes that we were focused on were any reports from the published studies about interventions, the impact of or effects of the interventions on mental well-being, physical health, and safety needs of women. But also, very interestingly, we included any information about the feasibility and acceptability of the interventions. So that was the framework for the study. We had a lot of elements that we included in this review. Sorry, Kathleen, I seem to not be able to advance this for some reason. I don't know why. I don't know.
There was a pop-up a while ago saying that the control had switched, Lori, so I don't know what that meant. But
okay. Oh, there we go. Thank you, Kathleen, for advancing that. If you did, maybe I did with one of my clicking. It reminds me, recently I did a webinar and there was simultaneous translation, or what was it? It was a national webinar. Oh, people for sign language. There was people doing sign language during it, and they really wanted me to talk very slowly. And they said one of the things that they suggested I do is that after every slide, to take a sip of water, and that would help to slow me down. It was very interesting, actually. We're not doing simultaneous translation, but that was interesting. So the methods that we followed, we being a certified JBI reviewer and trainer, we we're creative, maybe. I'm not sure if that's the right word to say this, but we incorporated a lot of different elements to guide the conduct of this review. And we utilized JBI methods for conducting umbrella reviews. And many of you would be familiar with that term, but if you're not, umbrella reviews are reviews of reviews. So have there been already systematic, some type of scoping or systematic reviews conducted that would meet our inclusion criteria that focused on the type of interventions we were interested in? So we included elements of that. So we did a search for published other systematic reviews, mixed methods reviews, so incorporating quantitative and qualitative evidence, and scoping reviews. So the methods that JBI has developed to conduct those three types. And if you're not familiar with this, JBI has developed methods to conduct 10 different types of reviews from different types of evidence, which is one of the very interesting components of JBI, I believe. And also, as I mentioned, we were very focused on doing this in a timely way. So we were focused on using elements of rapid reviews as well. So again, as early as we could manage to conceptualize the study, develop the protocol for the work, and then to implement the search strategy. In May of 2020, we conducted the search for studies, so published literature in these databases that are included here. And then in June, we did a search of the Nexus Uni database. And I'm very grateful for a librarian on our team that suggested this database. And we were able to identify media reports such as articles published in newspapers, magazines, newswires, and press releases that were published between March 1st and June 23rd, which is when we actually implemented that study. So that was incorporated within our larger review, but we kind of separated out those results and reported on them separately. But it was a very interesting element of the review as a whole. I had never done a search even of a media report database before or had synthesized that evidence. So it was a very interesting thing to do. I think with very timely topics, it can be extremely useful to do that. And one thing that JBI really focuses on, and Marilyn probably mentioned this earlier in the introduction, is that JBI really focuses on using the best available evidence to answer questions and implement and to inform policy and practice and future research. And in some cases, some of the best evidence could be from media reports. I could mention too that we only included print materials, and that currently is the methods that JBI has developed, methods to synthesize print materials and not other forms of media reports. So following JBI standards for rigor in conducting reviews, we had 2 independent reviewers conducting each task of the review process, and that included title and abstract screening, full text review, and data extraction. I seem to be stuck on this slide again. There we go. So many of you are familiar with this type of diagram, a Prisma diagram, to give you a summary of the entire project in some ways. You can see the number of records that we were first identified through the searches of both the database research and also the media report. And then the process of making sure that the sources are meeting our inclusion criteria. So in the end, we had a total of 24 research elements, I suppose. So we had 4 systematic reviews that met our inclusion criteria. So that's the umbrella review component. And then we had 20 individual studies that were not already reported in those systematic reviews. And then in addition, we had results of 51 unique media reports that were published as a separate report, but were represented as part of this PRISMA diagram. So yeah, you can see just a little bit of detail here about the studies, the systematic reviews, and individual studies that were incorporated. So all of the interventions that we reported on were basically drawn from all of these different studies, and especially the systematic reviews included many different interventions, of course, because those were synthesis of individual systematic reviews. So there was a lot of the interventions that were gleaned from those systematic reviews. But then in addition, as I mentioned, we included individual studies that were not already captured in those systematic reviews. And the research was published in quite a lot of different countries. So between the systematic reviews and the individual studies, we had research representing the United States, Canada, Germany, Australia, Hong Kong, and Tanzania. So not certainly representative of the whole world, but many different regions of the world. There we go. So just really briefly, this is a link if you're interested to see what the results of our media report was. We did not publish this as a peer-reviewed article. Excuse me, but we did prepare a report, and it's publicly available through the link on this website that I've included here. One of the things that I found fascinating about the media reports was that I think it's just the nature of media. There, in the RA, the research assistant worked really closely. We had one research assistant primarily focusing on the media reports and putting all that information together. Unlike research studies, there is often a report shared, and that is picked up by other media outlets. This was not, I'm not familiar with how media works, but we had to be really careful in the end to try to trace the source back to the original place where it was shared. And it was very common then for us to find many identical reports of the same information, but that's how media works. So we just needed to make sure that we were identifying unique reports and not all of the other ways that they were shared. So it was really quite an interesting process to do a synthesis of media database. And I do encourage other people, if they have a question that would be appropriate to look at media reports, to do it. It's quite an interesting way of doing synthesis work. And it's very helpful that it's one database to be able to search media reports. That was very useful. Okay. Am I moving the slides, Kathleen? It's just maybe having a little lag. So I'm eventually moving it. Okay. So just briefly, I don't need to share all that much detail, but when I talked about the 4 different groupings that we identified in terms of this framework that we were going to use to organize all of the interventions that were identified in the systematic reviews and the individual reports, we found that 21% of the interventions focused on preventing intimate partner violence. So these were designed to prevent or avoid IPV from occurring initially. They involved many different types of apps that might have related to education and awareness raising, making sure people were aware of different policies and legal protections in their particular location. So there was a wide variety of interventions, and about 21% that were in that particular category. And then in our second category, on the next slide, eventually we'll get there. So 23% were focused on identifying and documenting abuse, which was really quite interesting. So different types of interventions. So these were about providing information to help women understand and recognize IPV, enhancing awareness of behaviors that were abusive, supporting women's safety. This could be using online safety planning tools and apps, promoting public awareness and exchange range of IPV experiences, which is very interesting. So we included all of those in this grouping or category of identifying and documenting intra-partner violence. It might look like there's a little bit of overlap, but we really tried to carefully make sure that these fit within primarily within the 4 frameworks that we identified, the 4 levels of our framework that we identified. And then the third one on the next slide. Eventually, here we go. This seems to be stuck, Kathleen. I don't know, Kathleen, if it might be faster if you just do it and I not try to have control. I think it might be faster. We have a lot of slides and we could try that
Okay.
maybe.
Yeah,
I'm not
for
sure. I'm not sure if it'll be faster, but I can try to tell you when I'm done, or it might be clear when I'm done. The slide.
Okay. Yeah, I
there's
think this is the next one, is it?
Okay, yes, it is. Thank you. Well, I just don't want to cut into other people's time here. I could talk forever, unfortunately, about just one systematic review. And then about half, 52% of the interventions that we identified focused on supporting women living with and/or leaving an abusive partner. So this could involve alerts sent to contacts if there was abuse occurring. GPS tracking was quite an interesting one that could be used with different technologies. So lots of different apps, lots of different things to document abuse that was occurring. Service provision, ways of providing, help and support to people who were seeking help, and the process of leaving an abusive partner. Lots of safety planning kinds of things as well in this particular one. And then the next one, Kathleen, was the 4th part of our framework. Supporting women after leaving an abusive partner. This was a very small percentage, 4% of total intervention. So this is the person has left the abusive relationship, they're not going back, and it's really kind of about moving on. So again, there was a lot of things that were technology mediated, and as I mentioned, these were interventions that had to be able to be utilized during the pandemic. So it wasn't surprising that many of the interventions were virtual, even before the pandemic, ways of doing things in a socially distanced way. So it doesn't surprise me that a lot of them were technology mediated in some way, using technology to access the legal and justice system, which was very interesting, supports and resources to help people gain financial security, access to healthcare, personal safety, establishing future plans, and then some things around more permanent shelters and housing to support people in the longer term. So those were the 4 levels. So next, Kathleen. Yeah, so our key findings, and I'll go a little quicker here. I want to make sure others have time to talk. So how to talk about this quickly. So we did include, we were able to identify a lot of details in our report. You're welcome to read it if you wish. Documented things about incidence and severity, outcomes around mental health, impacts on relationships, and safety. We did find that, as with is so similar to many systematic reviews, that there was a lot of variation in how outcome measures were assessed. And that was really useful with really looking at what were the best tools that were utilized and most commonly utilized tools. And those really informed the current study that we're doing. In the process of doing this review, there was one of all the interventions that we found that really stood out to me. And it was published by Tewari and colleagues in 2010. So it was not a new one whatsoever, but it was a 30-minute empowerment session followed by telephone calls once a week for 12 weeks and access to a hotline. So that was an additional component. So if anyone had an issue, they could call a number to receive help and support. And there was really positive outcomes related to this intervention in terms of reducing depression and psychological aggression discussion, improvements in perceived support and the use of safety promoting behaviors. So this was an intervention developed in a different culture than ours. It was developed in Asia. The first empowerment session, I believe, was face-to-face, but the follow-up calls were on the telephone. So yeah, this was one that it just stood out to me in having really positive outcomes and really informed the AIM intervention that we implemented. So I won't dwell on this too much, but it does kind of help to kind of connect the systematic review to the AIM intervention. So there definitely was a lot of publication of unique studies, not a lot of replication studies. I think there is a lot of bias in the publication process to publish things that are new and different versus adding additional information and refining interventions. That's not quite as exciting as here's a brand new intervention that we tested. So there definitely was need for replication of studies. As I mentioned, so many different outcomes that were measured in different ways. So there definitely needed to be some consistency there. There wasn't a great diversity in the study samples, and we really identified that the utilization of an intersectional lens would be really useful. We didn't see a lot of studies focused on older women, and again, that's one of my passions. And we, not that any of the interventions specifically would exclude older women, but weren't specifically targeted to older women, and often then a lot of older women don't end up using them. And of course, we didn't find a lot of information at all in the studies that we included around the inclusion of people with diverse gender identities. So there were certainly some things lacking in the body of knowledge that we synthesized. There was certainly, we identified that it would be really helpful for interventions to focus on technology literacy and technology safety and security. With so many of the interventions in our review, we're focused on, we're really required, and we're using technology was a very important element. So making sure that people are technologically literate and are safe using those technologies, and especially safety in relation to the person who's abusing them. So, making sure that their browsers are cleared and such things. So that element is really important, especially with interventions related to technology. So yeah, providing that information around accessing and making sure people have access to, you need access to the technologies as the interventions are using those technologies, and including financial resources to help people access those things are really key. So those are some of the broad findings. So we can go on to the next one, Kathleen. So this was actually, Christy has joined us today. Christy's actually currently in Denmark, which is great, but finishing off her doctorate PhD in health shortly. So this was and Christy is very creative, is an artist, and really developed a really lovely infographic to really depict this different project. So that's the reference to it here. You're welcome to look it up, and it's published in the Healthy Populations Journal, a wonderful student-led journal that's published through the Healthy Populations Institute at Dalhousie University in Halifax, Nova Scotia, Canada. Okay, you can go on to the next one, Kathleen. So these are just some of the key things that Christy focused on in the infographic related to, again, so many things were related to technology, but all of these elements are really important. It's lovely to say we've developed this new technology, but we really need to think about safety around digital literacy, competence, safety, and security are really important to incorporate elements related to safety around using these technologies. The cost, it does cost money to have devices and to be able to connect to the internet for many that involve that. So that's really important. The access to especially people who live in places like low-income countries or rural and remote areas. So we really need to think about access to technology, whether the technologies are effective, and using more replication, I think, is really helpful. And again, focusing on diversity. And we really did not have much data on very specific, a lot of people, including older women, women with disabilities, immigrant or refugee women, women in the LGBTQ plus community, racialized women. So there was a lot of gaps in our knowledge. So that's all included in our infographic. We can go on, Kathleen. Okay, so finally, a little bit about the AIM study, and then Kathleen will talk more details. And I'm so excited to have many members to kind of use all the things that we learned in the review and in the project that we're doing now. So in the summer of 2020, so we had our review completed, certainly, and it was at least submitted for publication or under review or in some stage of the publication process. So I was really pleased to be invited to submit a proposal to the Public Health Agency of Canada based on a lot of the prior work that I had done in this area to submit a proposal. Of course, the timing was horrible. We didn't have much time to submit it, but we got it done. And the only reason we were really able to pull that proposal together was the systematic review that we had already completed, and really using the things that we had learned to really propose this study. So we can go to the next slide, Kathleen. Thank you. So this whole initiative is fascinating. And Kathleen, I don't know if you'll have time, but you could, mention that we're part of a community of practice, which is really exciting. So all of the different projects that were funded by the Public Health Agency of Canada, there had been a previous call. I think that those projects started the year before ours did. So many focused on many different other topics or people who were younger. We were part of this call that was focused on older adults. And in the end, there were only 3 projects funded in Canada under the older adult version of this. So Kathleen and our research assistant have just returned from the community of practice meeting in Montreal that was earlier this week. I think you just got home, Kathleen, didn't you? So the component focused on older adults was the purpose was to deliver and test health promotion programs and interventions designed to address elder abuse in the context of family violence. And if you know me, when I read that, it was like, oh, wow, there's just no way I can't apply for this. This is just not an option. But as I said, the timing was horrible. It was, summer, but we got it done. And again, the only way was that we had just completed the systematic review, and it's so much that we could build on in proposing this study. So the AIM program, so the AIM stands for the Advocacy Intervention for Women in Midlife and Older. It's highly individualized and tailored to meet the diverse needs of older women in the particular location where we are in the Maritime Provinces in Canada. So next slide, Kathleen. So we put together just a phenomenal research team of many people who I had worked with before, and some new colleagues, and lots of partners and collaborations throughout the region. And Kathleen is our research coordinator, but also our AIM program facilitators like Jennifer has been a phenomenal component. So you'll learn more about that very shortly. So next slide, Kathleen. So just really briefly, the people who are eligible to participate in our study are women who self-identify as a woman, are in midlife and older, about age 45 and older. We've had lots of discussions about age. Live in the Maritime Provinces, can participate in English or French. We are fully capable of delivering the intervention and doing the data collection in English or French. And that stage from our framework of the different stages of interventions, currently living with and/or in the process of leaving an abusive partner. So that was really identified from how we categorized interventions and what we felt would be really important. So we're doing our best to include diverse women, and specifically in our context. And some of these groups, our expertise of our team members and prior work that we've developed skills in working with, and characteristics of our team as well. So Francophone, new immigrants, visible and racialized minorities, and live in rural places. So that's not the only people that we wanted to include, but again, these are groups that we have prior knowledge and experience, and part of these communities for our research team. And I think importantly too, that we are not trying to control every situation that our participants are in, and they can be receiving other services. And in fact, a lot of our part of our intervention is sharing information about local services. So we're hoping that people do access other supports in addition to our own intervention. So next slide, Kathleen. So just really briefly, again, very much informed by that Tuari intervention, very much so. We reference Tuari all throughout, our study, because it's not identical to what they did, but very much informed by that intervention. So we did modify it in many ways, but we start with having a 1 hour approximately information sharing session. So this is delivered by our community-based researchers, our facilitators that are working with us. It's delivered virtually. It can be delivered as low tech as telephone, or it can be a virtual call such as Zoom. And there's 5 elements. First of all, information about older women and abusive relationships. And much of that is drawn upon prior research that myself and members of our team have conducted, in addition to other researchers. Awareness raising, safety planning, decision making and problem solving, and information about local resources. And then very interestingly, again, informed by Tuari through conducting the systematic review, the social support component. So basically, this is for 12 weeks. So after that information sharing component, about 20 minutes per session, but it can vary. But that's the kind of the guideline. Again, totally virtual, either telephone or Zoom. So these sessions are designed to provide encouragement and support and answer questions the woman might have. There's perhaps a strength and a challenge of this is that we haven't specified to our facilitators that they have to on session 1, this is the topic, session 2, this is the topic. It's not like that. It's really very, very tailored and individualized. Okay, next slide, Kathleen. So it is designed as a randomized controlled trial. And again, this is kind of because of the requirements of our funder, Public Health Agency of Canada, wanted interventions and developed and tested. And the gold standard way is to do that through a randomized controlled trial. So we're testing the effectiveness of the 2 components of our intervention for our target population, but also importantly, and again, I think we would have included this anyway, but it was a requirement of the funder to include a qualitative component, and we were very, very happy to do so. So in addition to the RCT and testing the impact of our intervention on our outcomes, we're also going to be interviewing the women who participated in the AIM program, and also our facilitators who are delivering the program. And we'll be learning from them about their experiences, their recommendations and suggestions for adapting and modifying the intervention in the future. So we're looking at the impact of the 2 components on the women's knowledge about IPV, about any changes in behavior due to the intervention, and any impact of the intervention on well-being. And then the 4th one is the qualitative component and learning from the experiences of the participants and the people facilitating the program. Okay, next slide, Kathleen. Yes, I thought this was the next one. So where we're at right now, we are in progress. We have began, time is just sort of January of 2023, if I remember correctly. was is that right, Kathleen? Yes, January of 2023, we officially began our project. We, as you can imagine, had a lot of things to do initially, including multiple ethics applications, which we were successful in doing, of course. So by October of 2023, we had all the approvals in place. We began to deliver the knowledge exchange sessions with our community-based researchers, our facilitators who are delivering the program. We've had Kathleen can give us updates of this, but we will be finished of our participant recruitment by the end of June. So we've had quite a long period, and this was a very important with working with various community-based organizations in the region, and different organizations had different timelines and different capacities to be involved in the work. So it was really important to have quite a long period of time of participant recruitment and having the baseline data collection done. And then by October of this year, all of the AIM program will finish delivery because as with all the follow-up time there, it does take quite a while. We are doing the data collection in addition to baseline. We'll be doing 3 month and 9 months data collection, and we'll need to complete that by July of 2025. And then by the end of 2025, all of our data analysis and dissemination work will be completed. So we're a little bit of a snapshot of the AIM study. So I think, Kathleen, you take over now and talk about the working with the delivering the intervention.
Yeah, I just noticed that we did have a question, so I might get you to address that, Lori, because it might be about your section. I think it's Michelle Purley. Michelle, did you have a question? I'll unmute you here. No, I don't. You must be muted yourself because I can't seem to unmute. Okay, that's all right. We can always come back to it as well. All right. So yes, I'm the research coordinator for the AIM study. It's been quite an exciting journey the last year since we've got the study up and running, and have been enrolling participants in the study and delivering the program to them as well. So I'm going to talk a bit about getting our facilitators trained to deliver the program. So first here, I'm just gonna bring up a map for anyone who's in other areas of Canada or outside of Canada. So just to give you a visual of where the study is being conducted, it's the provinces in red, so the maritime provinces, which is New Brunswick, Nova Scotia, and PEI. So how we began to sort of reach out to organizations to see about finding facilitators for our program, we began by developing a list of potential community-based organizations that could partner, that were sort of relevant to our study population. So organizations that delivered services and programs to victims of violence. So this included transition houses, second stage houses, women's centers, as well as other organizations that provided services and supports to diverse women in the maritime provinces, for example, Indigenous women, Black women, and immigrant and refugee women, for example. And to kind of help us develop this list, we use some government resources and publicly available documents. So each government in each province has kind of a web page which outlines the supports for victims of intimate partner violence or family violence. So that was helpful as well. You'll see kind of a logo on the right side there for THANS. That's the Transition House Association of Nova Scotia. So they have a website and you'll see a map there of Nova Scotia, which outlines all of the transition houses in the province and where they're located. And then Women's Centers Connect is also an organization in Nova Scotia, which kind of has a website and covers all of the, or outlines all of the women's centers and sexual assault centers throughout Nova Scotia as well. And the government of New Brunswick has a document called the New Brunswick Directory of Services for Victims of Abuse, which I think it's like almost 50 pages long, and it includes all of the names of the transition houses and second stage houses and domestic violence outreach programs in the province of New Brunswick. And then lastly, PEI, Family Violence Prevention Services, is an organization on PEI, which outlines all of the services that is offered there as well. So those different organizations and available documents were really helpful in sort of making a list, essentially, of different organizations to reach out to see who we could partner with. Okay. And so our list had approximately 80 organizations after going through all of those resources. So we sent out an email invitation to those organizations. And after receiving a response of interest, we asked each organization to have like a virtual meeting to discuss the study further. So we had approximately 20 virtual meetings with organizations. And during these meetings, we offered kind of two different partnerships, or two different ways that the organization could partner with us if they were interested. And so partnership one was kind of our larger commitment to the study, which would involve the organization identifying a staff member who could take part in a training session to become a facilitator of the AIM program. So they would be able to deliver both components of the program as well as recruit participants within the organization or community that they work in. And then our second partnership was more just sort of spreading awareness of the study. So that could be distributing our recruitment poster, and as well as identifying potential participants to recruit. And we were able to offer monetary contribution or monetary compensation for their contribution to the study. So the larger partnerships were offered $3,500, and the ones that help with recruitment were offered $500 for the duration of the study. And we had a total of 6 transition houses agree to help us out with partnership 1. And for partnership 2, we had kind of more of a variation in organizations. 4 of them were transition houses. 1 was a second stage house. 2 were domestic violence programs, and 2 were addiction recovery centers that were specifically for women in the Maritimes. And you can kind of see the total amount that, we provided to organizations, $21,000 for partnership 1 and $4,500 for partnership 2. So for all of you researchers out there, you can, participant recruitment is quite tricky, especially when it comes to victims of violence. So a lot of our resources is, going into participant recruitment, just to give you an idea of the numbers. So the duties of our AIM program facilitators included participating in a 2-hour knowledge exchange or training session, identifying potentially eligible women within their organization or community, and having discussions with them about the study and seeing if they were interested in participating. And as well as implementation of the 2 components of the AIM program, which Lori talked about, the delivery of the 1-hour information sharing sessions with participants and delivery of the 12 weekly social support sessions with participants. And lastly, once the program is complete, we're going to invite our facilitators to take part in an optional interview about their experiences as a facilitator and to get any feedback about any aspect of the program. And so what our knowledge exchange or training sessions look like, each session was scheduled as a 2-hour virtual meeting at an agreed upon time. We started with introductions. So we were looking to learn about each facilitator's kind of their background, education, and experience in the field as a frontline worker. And just to let you know why we have called it a knowledge exchange / training session is because one of our co-investigators, I believe it was Colleen McQuarrie from the University of Prince Edward Island, she suggested we use the term knowledge exchange because of the amount of knowledge and experience that each of these facilitators is bringing to the project. So they're bringing all sorts of experiences and working with this population. So we really wanted to highlight that and kind of how we were titling it. And so after kind of getting an idea of everyone's background, we gave an overview of the AIM study and what it involved. And for facilitators were given the opportunity to ask any questions about any aspect of the program. And then we exchanged ideas about supporting the needs of diverse older women who've experienced intimate partner violence. And we also provided an overview of provincial and national resources that could be provided to program participants. And we provided resources, to help facilitators support participants to develop goals and strategies for the future. And lastly, we had a discussion about project communication and documenting the delivery of the AIM program. So between October 2023 and May 2024, we delivered a total of 5 knowledge exchange training sessions with a total of 15 professionals and frontline workers in the field. Many of them had a background in social work or counseling. We had a couple of executive directors of, for example, transition houses, but many were workers within the transition houses or domestic violence outreach workers. And so in regards to enrolling participants in the study, both organizations, whether they agreed to partnership 1 or partnership 2, was similar in the way that they recruited participants. So they would share information about the study with women that they identified as potentially eligible for the study. So they would contact them either virtually or face-to-face if they were sort of working in the transition house, and asked if they were interested in the study. So had a bit of a discussion about what it was all about. And they asked the women if they preferred to reach out to the study if they were interested themselves, or if they were comfortable with a facilitator giving the research team their contact information so that we could reach out to them directly. And then once a participant showed interest, I did screen them for eligibility. And if they were eligible, then we did verbal consent over the phone, and then they were scheduled to do a baseline interview. And upon completion of the baseline interview, participants were randomized, and at that time they were notified of their group assignment. And if participants were assigned to the AIM program, they were notified that a program facilitator would be reaching out to them to schedule their sessions. And if they were assigned to the comparison group, we sent them a copy of our study materials. Basically, it's similar, the content that would be covered in the 1-hour information sharing sessions, but we're just providing it to them as a print copy or a virtual email copy. And they were notified that they would be contacted in 3 months for their first follow-up. And just lastly, I'm just going to talk a bit about, I think Lori probably covered most of this, but just how we're kind of collecting data with the participants. So as I mentioned, each woman will come in by doing a baseline interview, and then we do the 3-month follow-up and a 9-month follow-up. And the list to the right here covers all of the survey instruments that we're asking participants. So we're using the decisional conflict scale to measure the difficulty that women endure in making decisions about leaving an abusive relationship. The interpersonal support evaluation list to measure perceived social support, the women's experiences of battery scale to measure women's experiences of feeling fearful and controlled by their abusive partner. The IPV strategies index to measure the different types of IPV related strategies that women are using to keep themselves safe during or after their abusive relationship. The CESD is used to measure depressive symptoms. And lastly, the SF12 version 2 health survey was used to measure quality of life and health measures. And so those surveys are collected at baseline as well as 3-month and 9-month follow-ups. And we also collected some sort of generic or basic demographic information at baseline from the participants. And then for qualitative data, I know Lori had already kind of mentioned this, but we're doing interviews with program participants as they kind of flow through the program. So once they've completed their first initial session and all of their social support sessions, our research team will reach out to them and ask if they're interested in doing an interview about their experiences in the program and to ask for any ways that it can be improved. And then once all of our facilitators have completed delivering the program, they'll be invited for an interview as well. And on that note, we're now going to have one of our program facilitators, Jennifer Fraser Furrow, talk about her experiences delivering the program. So Jennifer, I will pass it over to you. And if you're okay with it, I will just go through the slides as you let me know when you're complete. And then it just seems to be a little quicker. We can give control, but it's a little quicker just to do it on one end, I guess. So I'll pass it over to you, Jennifer.
Wonderful, wonderful. Yes, thank you for taking control of the slides for me. I appreciate it. So good morning, everyone. It's a pleasure to be here today with you and to share a bit about the delivery of the AIM program that I took part in. So next slide, Kathleen. So with this research project, as both Kathleen and Lori have mentioned, it's been delivered either by community-based researchers or interventionists. So I was not attached, I am not attached to a community-based agency. I delivered the intervention. The community-based researchers would receive their participants through their interactions, while myself as an interventionist, I would promote the research project in communities with in-person or virtual poster distribution. The interventionists, myself, participants' first point of contact was usually with the research coordinator. And then they would call the number on the poster that they would have seen that would have been distributed. So my role as the interventionist in this project involved the poster distribution, delivering an information session to new participants that were randomly selected to receive the AIM intervention, to provide 12 weekly support sessions to these participants, and to log the details of each information and support session. So we're on slide number 3, Kathleen. I'm not sure if I mentioned that. So the information sharing session was about 1 hour, and it was delivered by telephone or virtually. So the information shared during this session included a brief recap on what their participation would look like in the study. So the information session and the 12 sessions that followed that. Information about older women and abusive relationships, awareness raising, safety planning, digital safety, decision making and problem solving, and information about national and provincial resources. So participants were often intrigued with the information about the wheels of power and control, warning signs, red flags, and the ways that IPV can present or evolve within a relationship. The information shared during this session is also shared digitally with participants after we're done with their consent. So the information session that I delivered to participants ranged from 45 minutes to 1 hour, depending on how involved the participant wished to be during those sessions. Some sessions actually ended with us not having time to cover all the information within 1 hour. So we would finish or agree to finish during our next and first support session. So during these sessions, some participants have presented displaying strong emotions. So emotions that could be defined as sadness, frustration, anger. And during these information sessions, many participants have been very engaged in the session, sharing many things, such as reasons why they chose to participate in the study, speaking at length about their current situation at different points throughout the session, resources they have accessed, and even offers to share information about these resources with myself. Reflections on their relationships and situations, past and present, spoke about their children, shared about systematic issues they have faced, the uncertainty that they have felt, shared suggestions on ways to support women who have experienced IPV, shared life stories, talked about experiences with service providers, law enforcement, and the court system, and shared relief, the relief that they felt in being able to speak to someone about the situation they have or are facing. Next slide, Kathleen. So the social support sessions are provided weekly for 12 weeks by phone or virtually. Session times were expected or estimated to be 20 minutes. These sessions were designed to provide encouragement, support, and to answer questions the women may have. And there was no specific or scheduled topics that are planned for these sessions. They're very individualized and based on the needs, questions, or topics their participant wishes to discuss. With the participants that I've worked with in the study to date, the sessions have ranged from support sessions have ranged from 10 to 20 minutes for some, while others have needed upwards to 1 to 1.5 hours per session. The varying length of the support sessions have been discussed with the team at different points through the study. Participants have presented, again, with an array of emotions during these sessions. Again, strong emotions that can perhaps be identified as fear, sadness, frustration, and anger. And these were often when there was a current situation that they were struggling with. At other times, the tone of the calls could be quite light, and the participant may not touch on any IPV issues at all. Participants have used these sessions to discuss their current situations, resources, feelings, systematic issues, and other topics. Participants have used these sessions to talk about things like their current, evolving, or past experiences with IPV, their current or past partner contact, their experiences with IPV, previous experiences with IPV, new relationships, and watching for IPV red flags, emotions surrounding their ex-partner entering new relationships, contact with past abusers, questions if they were experiencing or have experienced, if what they experienced was abuse at all. Especially if the abuse was not physical in nature. Contemplating leaving a relationship where IPV is present. Safety planning. Safety plans they've used or have set out, or, you know, maybe safety plans were an entirely new topic to them. EIOs, peace bonds, child alienation, safety, grief and loss, mental health struggles, past trauma, substance use, disability, accessing therapy, court experiences within family and criminal law, experiences with lawyers' fees, child and spousal support, income, housing, and this would have ranged from different types of housing to homes, to shelters, to supported housing, transportation, financial concerns, health benefits, friends and family, interactions with community agencies, government agencies, and schools, experiences with local agencies, speaking out about IPV publicly, and privacy issues. Participants also talked about system issues such as limited IPV supports, court systems, privacy and safety, limited evening and weekend hours by support agencies, and gaps in the systems and supports. And this would have been from their experiences. Resources shared with participants have included local IPV agencies and programming, family law, income resources, transportation, food safety, employment resources, housing subsidy information, mental health supports, substance use supports, no or low cost therapy, goal setting, and peer supports. Participants have shared feelings of being scared, lonely, bitter, angry, vulnerable, overwhelmed, grief, loss, confusion, being trapped, demoralized, frustrated, angry, and sad. But participants also use this time for lighter topics, such as furthering their education, retraining, goal setting, spirituality, other experiences in their day-to-day lives, community involvement, hobbies, aging, health, self-care, organization, their financial futures and the use of financial planners to do so, and setting boundaries. Next slide, Kathleen, please. Participants shared their need for flexibility when booking sessions. Preferences for weekday, weekend, morning, afternoon, and evening appointments were always accommodated. During the study, there were times when participants would need to cancel or reschedule in advance. There were also times when last-minute changes such as canceling, rescheduling, and no-shows occurred. Participants were accommodated and rescheduled for a day and a time that worked for them. At times, participants were not able to commit to weekly sessions. These requests were also accommodated. Participants' interactions with myself, the interventionist, were also varied. Some participants requested reminder emails about upcoming weekly sessions. These requests were accommodated. Some participants would send emails between sessions with updates on situations or exciting news. Some participants shared that they appreciated the support sessions as they did not have anyone to talk to, or that they trusted to talk about what they were experiencing or had experienced. Or if they did, they figured their trusted support people were tired of hearing about it. Next slide, Kathleen. Participants were offered to meet virtually or by phone for the information and support sessions. The majority of the participants I worked with chose virtual, though other times phone was chosen based on accommodating participants' needs, or if they were experiencing technology issues. These requests for change could come in advance or last minute, and they were always accommodated. In my experience, with the participants, regardless of the delivery method, virtual or phone, I noticed no difference in the connection that was able to be made with the participants during these sessions. Next slide, Kathleen. In the time that I've spent delivering this intervention, I have heard of many gaps in our systems. Community agencies, police, social development, the courts, lawyers, and enforcement within the province of New Brunswick, where I am based and my participants were located. Systems that did not acknowledge certain forms of intimate partner violence. Systems that did not allow for supporting older women and their adult children or their family unit, as however it was, with support. Systems that did not support and enforce court orders. Systems that did not fully support women trying to flee intimate partner violence and their many needs. Systems that do not support women navigating situations with an ex-partner that involved intimate partner violence. Systems that do not support healing after fleeing intimate partner violence. And systems that do not support women in the process of rebuilding after fleeing intimate partner violence. I began my career in the social service, working with agencies that exclusively serviced women. It has been a pleasure again to work with and support women exclusively through this study. And again, it has been a privilege to learn alongside these women as they share their experiences, their thoughts, feelings, and ideas with me. Just as so many participants wish that their participation will help other women in the future, I too share this hope. Next slide, Kathleen. Now, if there is any questions or comments, feel free now, but Kathleen, I don't know if you have time set aside for that later in this session.
Yeah, Marilyn, I'm not sure either. Do we want to hold questions till the end or have a chance to do some now? Or Lori?
Sorry,
yeah.
I was muted, Kathleen. Why don't we take a few now?
Okay, for sure. All right.
If not, I mean, we can certainly continue on, but sometimes people have a burning question and they really like an opportunity sooner rather than later. If not, no problem. We can continue.
All righty. Okay. So our next speaker, I'm just going to advance the slides here. Our next speaker is Jennifer Parley, and she's a social worker in the adult protection field with the government in New Brunswick. So she's going to be talking about adapting the AIM intervention for adult protection workers in the province. So Jennifer, whenever you're ready to take it away.
Thank you. Thanks for having me. I'm really excited to be here. As Kathleen mentioned, I'm a social worker. So my role as a clinical learning specialist, so I work with social development in New Brunswick. And so I work on developing and giving training to social workers who work with our adult services programs. So we have adult protection, long-term care, and the disability support program. So those are the programs that I work with and support those social workers to develop some training. So if you want to go to the next slide. So, oh, sorry, the next one too. So in today's presentation, we're going to learn about social development and the adult protection program in New Brunswick. I thought we could review some relevant statistics related to IPV in New Brunswick and Canada, just to give people a context of where we're coming from. We'll look at discussing the connection to the AIM study, and I'll provide a brief overview of the IPV training that I'm currently working on for our adult protection social workers at Social Development. Okay. So social development is a branch of the government of New Brunswick, and we provide programs and services to provide protection and care for individuals and families while fostering independence and self-sufficiency. And we work with a lot of community partners and service providers who play an important role in contributing to a safe, secure, and healthy New Brunswick. So with adult protection, we do investigations of suspected cases of abuse and or neglect in communities, in the community, in nursing homes and special care homes in New Brunswick. We do referral services for like home support and residential or placement services. So if a client wants a nursing home placement, for example, case management for ongoing support. We do court-ordered supervision. So sometimes we have a court order for a client, so we are able to make decisions on their behalf. And we do other trustee and guardianship duties as required. And our adult protection services are offered to older adults and adults with disabilities who are 19 to 64, who are victims of abuse or neglect. And for in adult protection, an older adult is defined as somebody that's the age of 65 years or older, or if we're not sure of an exact age, that appear to be the age of 65 and older. So that's kind of the age when I'm working on our training for IPV that we're working with is 65 years and older, because that's part of the standards in adult protection. Because as we know, and as Lori mentioned too, you know, the age range for considering older adults is different depending on the research and the studies that are being conducted. So for this training that I'm developing, it's for adults that are 65 years of age and older. Okay. Oh, just back one more. Yeah, thanks. So New Brunswick has the highest rate of police-reported IPV in the Atlantic provinces. So more people are killed by their intimate partner in New Brunswick than any other Atlantic province. In Canada, 30% of women experience IPV in their lifetime. And according to a study by Justice Canada, the cost of IPV per year in Canada is $7.4 billion. So in New Brunswick, it's $165 million a year. So some of those costs would include the victim survivor costs, the justice system costs, and other third-party costs. Okay. So connecting with the AIM study, in November of last year, I was part of a working group on intimate partner violence, and it was to kind of determine that we wanted to develop something for our adult services social workers, because there was already training in existence within the department for our child and youth well-being social workers, but nothing specific for our adult services or specifically adult protection. So I took kind of what existed for our child welfare side of things and took that information, what I could from that, and started working on the training for our adult services side. And in conducting my research online and, you know, doing some research with scholarly articles and things, I kind of came across Lori's name in a variety of articles that I had found in discussing older adults experiencing intimate partner violence. So I thought, okay, I'll just maybe reach out and see if I can, you know, connect with her and pick her brain and see what she thinks about this and what information she might be able to share with me. And thankfully, Lori, you know, was kind enough to meet with me as well as Kathleen on several occasions to discuss the work that I was looking to do and what kind of training I was looking to provide to our social workers. And they kind of tweaked their training that the other Jennifer would have received to kind of fit with what I was working on for our adult protection social workers. So it was that diverse older women in IPV training that they kind of adjusted to meet my needs. And so that was a big piece of the puzzle that helped me work on developing that training further, and also connecting with other experts in the field and things of that nature, so we can kind of build a robust and you know, best practices and things like that for our training for our adult protection social workers. So that's kind of how I came to be a little piece of that is just that kind of connecting with Lori and helping and providing me some guidance and support to know what to kind of include in my training for our social workers. So okay. So again, the focus of the training is engaging our adult protection clients around IPV issues, understanding the impact of IPV on the victim survivor, and making decisions and plans to increase safety. So that's kind of what I'm focusing on for the training. And the training is designed to strengthen participants' skills and deepen their awareness of IPV, specifically in older adults, along with best practices in adult protection. Because, you know, as we've mentioned too, it sometimes can be hard to define IPV, and not everybody's aware of the different types of IPV and things. So just making sure that's clear for our adult protection social workers that are doing those investigations with the victim and survivor as well. So that's kind of what the goal of the training will be. So, so how will our participants learn? So we're looking at a trauma and violence informed approach. We're having an intersectional lens, looking at, again, like I said, the definitions of the various types of intimate partner violence, having case studies and examples of as close to real life as we can get, to give our social workers that understanding of kind of what to look for when they're doing their investigation, practice interviews, so coming up with you know, questions and how to support the victim and survivor and question appropriately, intervention strategies, and again, collaborating with community partners and other involved individuals while supporting the victim survivor through their experience of IPV. So that's kind of the approach that I'm looking at, is trying to get it as close to a real life example as possible, so that when they're in the field, that information is there for them to access and know how to intervene appropriately. Okay. So some of the topics in the training that I'm working on would be challenging assumptions about IPV. We all, you know, hear these different assumptions and things like that. So really being mindful and aware of those assumptions and trying to avoid them. Learning about the various warning signs of IPV in older adults. Learning about and discussing how older women might be experiencing IPV in different ways. Some of the barriers that the clients might have to leaving or even disclosing to the social worker that's involved. Looking at assessing risks and dangerousness, so the various kind of tools that are used in that. So the danger assessment would be one of them, for example. Safety planning with an older adult, so that might look a little bit different for an older adult. Looking at kind of a unique factors of competency, cognition, and dementia, and how that might play a role in somebody experiencing intimate partner violence, or disclosing or understanding that kind of thing. So that is a big piece that would be different from the training from the child and youth well-being side of things. So that it's having a hard time kind of trying to find all that information, because there's not a whole lot of research and things. So trying to get as much information and best practices for that. Also looking at trauma and the impact of aging on, so that lifelong experiences of trauma. Looking at diverse populations, that intersectionality piece that Lori talked about as well, because that's going to play a big role in how a social worker is interacting with the victim survivor, and also providing resources, again, provincial and local community resources, so that the social worker is able to support the client in determining next steps and what that might look like for them. So that's kind of some of the topics that I'm looking at, including in the in my training that I'm working on right now. And of course, there'll be other things come up as we go. You know, as I'm doing my research, I'll find research and information about something, and then something else will come up. So then I'll kind of go over and work on something else. So it all kind of interconnects and works together to come up with a fulsome training that I'm trying to develop for our staff at Social Development. Okay, and so that's my part. That's kind of just like a very general overview of what we're doing at Social Development with our adult protection social workers and IPV training. So this would kind of be the first full training that we would have in a very long time on this topic. So that's my piece. So if there's any questions or anything, I'm happy to answer as best I can as well. So thank you.
Thank you so much, Jennifer. I'll just jump in here for a sec. Kathleen, you mentioned when you share your screen, you can't see everything. I see that Vincent has his hand up right now. So I don't think we had any more slides. We just have a list of our references and contact information. So feel free to share those slides. But Vincent, please go ahead with your question.
Thanks, everyone. And thank you all so much for sharing this. This has been really wonderful. As a social worker myself, who's actually currently working with folks who are facing intimate partner violence, this has been extremely helpful in helping me to develop those interventions. I do have a quick question for Jennifer, actually. This training seems very interesting and, of course, very related to my field. I wonder, specifically in the intersectionality piece, I work a lot with LGBTQ2S+ populations. And this, I think, is a population that is often left out of conversations around intimate partner violence, whether that's with men or in this case, specifically with women and other gender marginalized folks. And I wonder how you have, like, what the strategies you've had so far to integrate the realities of like 2S and LGBTQ+ women into that research. And I'm also kind of just thinking about the particularities of that, and so how epistemic injustice might lead some of these queer and trans women to not even recognize intimate partner violence because it's not represented as something that they might live in a queer relationship, or especially in the case of older adults where people might end up having to like go back into the closet in housing and care facilities, and how that might impact things. So yeah, any reflections that you might have on that would be greatly appreciated.
Yeah, that's a really great question. And it's certainly something that to be mindful of. And when I'm kind of developing the training, I'm trying to use kind of more gender neutral terms as well too. So we're not just assuming, and that's kind of part of when I was talking about the assumption. So we're not one to assume that the victim survivor is always female and that the perpetrator is always male. So trying to recognize that it does happen in same-sex or gender diverse couples as well, and just trying to make sure that we can't assume that it's going to be the male be the perpetrator and the female is going to be the victim survivor, and making sure that we have those open discussions and having it recognized. And when I'm doing my case studies examples as well, is trying to have gender diverse case examples as well, because even, the participants there could be gender diverse as well. So trying to make sure that I want it to be as inclusive as possible, and making sure that we're staying away from any assumptions that we might have on who the victim survivor is and who the perpetrator might be as well. And I know, so that's kind of how I'm trying to address it, honestly, is just to make sure that we're keeping an open mind and not assuming anything, and trying to be using respectful language and things like that as well. And just and that's one of the areas that I'm working on in developing, and also that intersectionality piece of other identities that might play a role into it as well. So we've got also in New Brunswick, many Francophone as well, and people that live in rural communities and things like. So all of those things are kind of going to be playing a role in our approach and how we're supporting the clients that we're working with as well, and making sure that we're as inclusive as possible, and not and trying to avoid any assumptions and things like that. And it might be that we make mistakes, and that's something that we can certainly learn from and develop further. But I think it's a good point to make sure that is definitely on my radar, and definitely want to make it sure it's part of the training, so that we're not missing the boat. We're not missing a key demographic, because it's an important topic to address, and make sure that we're not forgetting and leaving something out, or making assumptions as well. And for going back into the proverbial closet to go into a nursing home or special care home, I haven't necessarily seen that in my experience as well. When I was doing adult protection and doing those investigations in nursing homes and special care homes, to me, what I was seeing was a very inclusive environment and very supportive environment. And I hadn't seen anything to suggest that might, have to. And I hope that people wouldn't have to feel like that would be something they would have to do to fit in, or feel like they would fit in at one of our facilities in the province, but it's certainly something that to be mindful of as well, and to be aware of, and keep in the back of our mind that that's a possibility as well. But so far, knock on wood, I haven't seen anything to suggest that that's an issue, and I hope it wouldn't ever become an issue for sure. Yeah.
Great, thank you so much. And I will add that there's maybe a bit of data also around that. I know that Dr. Jackie Gahagan, based at Mount St. Vincent, has done some really great work around folks being forced back into the closet in those spaces. So I think specifically in Atlantic Canada, she's the current associate vice president of research at the Mount, and so yeah, great person to contact in case you're looking.
Wonderful.
Thank you so much.
Thank you. That's wonderful.
If anyone else has any questions or comments, you feel free to write them in the chat or raise your hand using the system. Either is fine for any of our speakers. Marilyn, I see your hand up.
Yes, yes. Given the stage that the project is at, just wondering if you've encountered any surprises or anything unexpected to date.
Oh, such a good question, Marilyn. Well, I'll start, but I'm sure the others have had lots of things too. We originally were anticipating focusing on age 50 and up-ish. I mean, age is always such a difficult thing with everything that I do. We kind of define this as women in midlife and older, and Kathleen and I have had lots of discussions about this, and we did reduce the age to 45. And I just wanted to mention that because that is not an ideal. We have a study that includes people age 45 and up. That is like huge age range. Um, and yeah, but the most interest, I think, has been for women who are younger in their 40s and 50s. And we have a small percentage who are 60 plus. So to me, that might have been one of the surprising things, that there seems to be need, at least in the region, for women who are in their 40s and 50s specifically around this topic. And that's probably the group that's been the most interested in, or the group that our facilitators and who've been able to recruit, and all of our recruitment strategies, that's what we've resulted in. Given that, and many people who are not from our region wouldn't know this, but we have quite an aging demographic in the Maritime provinces. We have a large proportion of people who are older adults. So, maybe there needs to be different, more targeted interventions at women who are older than this. So it's been primarily focused more on women in midlife. But that was just one thing that I've been reflecting on a lot. But what about the others? What has been surprising?
I'll just jump in for a quick comment here. Myself, like, I didn't have any experience as a frontline worker in the field, so my background is just in research. So I just feel that I learned so much having those discussions with the community-based organizations and realizing just how strapped they are for time or staff time, resources, that sort of thing. So, and I think, as I mentioned, like, we had discussions with about 20, and we had, 15 agree to partnerships, but not all at like the higher level, some with just recruitment. But a lot of them really thought this research was important and really wanted to help, but unfortunately, they didn't all have the capacity. So, that was just kind of one thing that, I think I learned a lot from that, just seeing how things actually play out in the real world. It's really important, and they want to support older women and have, services for older women or women in midlife and older. But unfortunately, it just wasn't feasible for every organization who was interested to partner with us and to help out. So that's just one thing that came up quite a bit. So. Yeah.
Is it still a question asking time? Okay.
Yes, for sure.
Thank you so much for the presentation and sharing information. Something that I guess I've been thinking about, or I had a couple of questions. One was in relation to kind of like the community sites, and so the folks that like the community-based researchers, or the other words, I can't remember, started with an I, the folks that were like the first point of contact with the research coordinators. Were those primarily from nonprofit organizations, or were there any kind of services or program sites that were located in like the formal publicly funded health system? I guess I was just wondering that.
Yeah, that's a really good question. So I'm pretty sure all of the organizations that did agree to partner with us were nonprofit organizations, like mostly transition houses, there was a few other, but like a lot of and just to kind of speak generally, a lot of the transition houses in the provinces have kind of an umbrella of services that they offer. So they might have the transition house and second stage house and outreach services kind of all within the same association. So there's a bit of variation that way, but yeah, they were all not-for-profit organizations.
And is that just because there are no like that's who's doing this work? Like, yeah,
Yeah, definitely. Yeah.
yeah. And so I guess I'm holding that in um conjunction with, I'm like in my mind the first one of the early slides, Lori, that you had, that you spoke to, that had like what is primary, what is secondary and tertiary, and the theoretical model that you had used to structure and organize the papers and findings. The model itself didn't address primary, like the what are the roots of this. This model didn't address that, and so the papers and things that we're drawing from are looking at working with folks who are, you know, currently experiencing, or who are kind of left and recovering from I think, as Vincent acknowledged, and I would like to echo, like a very kind of heteronormative understanding of interpersonal violence.
Mhm.
And so I often, I guess I'm thinking, you know, the government will acknowledge and kind of provide some money for some of these things, but isn't taking up that work in and of themselves. And then even the interventions that then do come up are focused on the visible violence, like the you know, one human and another human that we can kind of like visibly see. And I'm interpreting the lack of funding, the precariousness of this work as violence in and of itself, as like a form of structural violence that's embedded in kind of the way that we live, where interpersonal violence is really something that I see as like a symptom of something larger, and I'm sure I'm not the only one. But I'm just wondering if, like, in your work, or in some of these papers and things, and like all of the masses of information that you've like spent, you know, screening and reading and organizing, if there's been any kind of discussions around colonial logics of gendered violence, and maybe like how do we think about that in the way that we address our research, or design interventions. And so, like, you know, Vincent's comment again around like the lack of inclusion, like thinking around how, in order for us to decolonize, we necessarily have to challenge heteronormative ways of thinking, where like gender-based violence can be a way to even reinforce heteronormative relationships that benefit the state. And so I'm just wondering if, like, people are like with someone who has a finger on the pulse of a lot of the research, like if that's a discussion that's happening anywhere that you've kind of come across. It's a lot, sorry.
Yeah, Ivan, thank you. I'm in a library, so I'm trying not to speak loudly. I was in a private room, but my time ran out. um, yeah, your thoughts are fascinating, Ivan. I think such an important. I'm thinking that kind of this is such a great final comment. I know our time is probably up, but reflecting on how this was really based in a systematic review work of existing literature and kind of using the framework we came up with to categorize the interventions that are there. I goodness, I really don't think that there was any interventions that I can recall that we screened that were included in our study that really use these lenses of decolonizing. And I do think there's, kind of a heteronormative lens, as you mentioned, that is probably used in this work. And it's a tension and a struggle that I have. Our focus was specifically on violence against women and people who identify as women. And I tried to acknowledge earlier on in the presentation that this is not focused on everyone, and that is exclusionary unto itself by using that language. So what I think would be fascinating is to really undertake a systematic review where you're really looking at the lenses and the what is guiding the work, and because that's going to have an influence on when interventions are developed. So yeah, I think those are, you mentioned a lot of things there, but I think a review of interventions that really are looking at non-heteronormative lenses or looking at decolonizing ways of providing supports, I think would be absolutely fascinating. Unfortunately, I'm not sure if you would find a whole lot of sources included in such a review, but sometimes just asking these questions is the important thing, right? And seeing what is there and what lenses are being used and what is not being done and what is being excluded, I think is absolutely important. So thank you. That I think, Ivan, there's a lot there to reflect on, I think, and I really appreciate your comments there and building on what Vincent said there as well. So thank you. I'm afraid we might have to wrap up, Kathleen. I think we're a little over time, but this was, yeah, thank you all so much. I'm really pleased we had such great attendance, and these are recorded and people will be able to connect in globally. This might not have been a great time for folks who are in way far parts of the world. So hopefully we'll have some people who listen to the recording, and yeah, thank you. And thank you so much, Kathleen, and Nadia as well, who's our research associate with our JBI Center, for helping us get organized today.
Thank you. Thanks everyone for joining us.
Okay, have a great day.